Everyone. Thank you for joining tonight. We have a great presentation by Dr. Matt Brown, one of our hip and knee surgeons here at Rothman Orthopaedics. Just a couple of things. If you have any questions throughout the presentation, please feel free to enter them at the Q&A box at the bottom of your screen, and Dr. Brown will take time at the end to answer as many as possible. As I mentioned, and I know Dr. Brown will tell you a little bit about himself, but he is a hip and knee surgeon here at Rothman. He sees patients at our Chalfont, Doylestown, and Willow Grove offices. You can take it from here, Dr. Brown.
Hey, thanks everybody for joining. We're going to have a talk about partial knee replacement today. And like Natalie said, my name is Matt Brown and I work at the Rothman Institute, and I'm also an assistant professor at Thomas Jefferson University Hospital. A little bit about myself. I grew up in Oneonta, New York, which is, you can see it on the map there. It's about 4 hours from here, well used to the snow and cold weather. I went to undergrad at Georgetown University in Washington, D.C., and then I went to medical school up in Rochester, another snowy place. And then I went down to Wake Forest in Winston-Salem, North Carolina for residency training, and I did a fellowship in hip and knee replacement at the Scripps Clinic in San Diego, California, where they don't get too much snow. Um, Prior to joining the Rothman Institute, I worked at St. Luke's University Health Network, primarily in Quakertown and Allentown, and then I spent 4 years at Cooper University Hospital in Camden, New Jersey, and I've been at the Rothman Institute for the past 3 months and really enjoy it here. Um, so, what is knee arthritis? Knee arthritis is really the medical term that we give to cartilage wear and tear about the knee. It can really affect any joint, but we're going to be talking about the knee today. And you can see on the photo that that is a picture of normal cartilage, which is sort of a cap on the end of the bones that allows them to move with minimal pain and friction. And you can see on the picture with the arthritis, when the cartilage becomes damaged, it doesn't allow the knee to function properly, and it can cause pain, stiffness, instability, and it can also cause pain with walking and standing. The treatment pathway for knee arthritis starts with non-pharmacologic things, including physical therapy, a cane to help people ambulate with less pain and instability. Exercise also helps, mild to moderate activity to keep the muscles working properly. Also, weight loss, if people are overweight, can help to take stress off the joint and can help alleviate pain. That would be the first step. The second step in the pathway would be medications. So, Tylenol, anti-inflammatory such as ibuprofen, Motrin, naproxen, or Aleve. Those things have all been shown to help. Topical medications such as creams or gels like Voltaren gel, Tiger Balm, Icy Hot, things of that nature. A third part of this would be injections. These can really help people with pain relief. Cortisone is a type of steroid, and steroids are an anti-inflammatory, which help decrease the amount of inflammatory chemicals that are in the knee related to arthritis. And inflammation causes pain and swelling. So cortisone injections are designed to decrease the inflammation in the knee secondary to arthritis and help with pain and function of the knee. The second thing listed is viscosupplementation, and this is really a medical term for synthetic joint fluid. And arthritis can cause a degradation of the joint fluid that is a lubricating fluid in the knee that helps the cartilage to function properly. Inflammation causes the cartilage to, or the synovial fluid to degrade and not work properly. So viscosupplementation is really a synthetic joint fluid to help the damaged cartilage function as best as it can. And finally, if those things do not work, there are surgical interventions. And this is really what we're going to be talking about tonight. And those include partial knee replacements and total knee replacements. Um, so we'll move on to talk a little bit more about that. Partial knee replacement is only replacing the damaged part of the knee, and it preserves the other parts of the knee that may not be damaged. Um, there are three compartments in the knee. There's a medial compartment, there's a lateral compartment, and then there's a kneecap joint. And the pictures at the bottom show a medial compartment that has no space left between the bones and has bone on bone end stage arthritis. And then you can see on the picture there, that's a picture of a partial knee replacement that's replaced only the damaged cartilage on the medial side of the knee. So that's what we call a unicompartmental knee replacement or a partial knee replacement. A total knee replacement, this is a photo of a total knee replacement, replaces all of the cartilage in the knee. And you can see from this picture a front view and a lateral view of the knee with a total knee replacement. So that's what a total knee replacement and a partial knee replacement are in brief terms. So, um, partial knee replacements are associated with a smaller incision. They are associated with a faster recovery, and they also feel more like a normal knee or an undamaged knee compared to a total knee replacement. There's also a lower overall risk of complications related to partial knee replacement compared to total knee replacement. And the partial knee replacement is again on the left side of your screen. A total knee replacement, as we talked about, um, the entire knee joint is resurfaced or replaced. It typically has compared to a partial knee replacement, it typically has a longer recovery rate, typically by about 3 to 4 weeks longer. Total knee replacements do provide very good pain relief, but ultimately patients may describe the total knee as feeling a little bit more mechanical compared to a total knee replacement. Um, and total knee replacements uh, are appropriate for patients who either have partial knee arthritis or if all of the knee is affected by the arthritis. So, who is a candidate for partial knee replacements? Because partial knee replacements sound great, but not everybody's a candidate for them. So, you really have to have arthritis that's mainly isolated to only one of the three compartments. You can see in the picture at the bottom left what a healthy knee looks like, and then you can see in the middle picture there's only part of the knee is damaged, and then the photo on the uh, far right shows a knee that has damage in more than one compartment. The knee ligaments also have to be stable, and we really only recommend surgery if other treatments that we talked about previously haven't been helping. And thankfully, this topic has been studied, well studied, and there are radiographic decision criteria that you can just briefly see here. We're not going to dwell on them, but these help your surgeon to determine ahead of time who would really be a good candidate to consider partial knee replacement and who really would be better to have a full knee replacement. So we do have radiographic criteria which have been well studied that help us to guide our patients in terms of decision making regarding total versus partial knee replacement. Um, so the surgery itself, what does it entail? It really takes us about 30 to 60 minutes. All the cartilage and a small amount of bone in the damaged part of the knee is removed, and the bone is carefully shaped to accommodate. You can see the starting picture on the left with the damaged cartilage, and it almost looks like potholes in a road that maybe are occurring now because of all the snow plows. But you can see in the second picture from the left that the bones have been reshaped and in preparation for the partial knee replacement. The middle picture shows with some small trials in that are very similar to the actual real implants, and they allow us to test the knee and make sure that it's functioning properly. And then the final picture on the far right shows the actual partial knee replacement implants in place, and the surgery is basically over, and then we just have to close up the knee, and that's pretty much what that entails. The uh, surgery itself, again, takes about 30 to 60 minutes, and you are actually able to get up and start moving around the same day. That actually happens to be a picture of Al Roker that I found after his knee replacement. Um, Thought that was amusing. He looks pretty happy. So physical therapy starts that same day. We typically would provide exercises and instruct you in what to do. And most patients are getting back to pretty normal activities within about 3 to 6 weeks, but full recovery may take a few more months from that. Um, so this is just a little bit of research showing a partial knee replacement, which is labeled UKR. Those are the gray bars in the graph compared to total knee replacement. And again, you can just see that patients overall are having more good to excellent results with a partial knee replacement compared to a full knee replacement. And again, partial knee replacements, it's a smaller surgery. We're replacing less of the knee, so there's a little bit smaller incision. The recovery's a little bit faster, a little bit less blood loss. The real bang for your buck for me though is that there's a lower overall risk of medical complications with partial knee replacement. And after patients are recovered 2 to 3 months after the surgery, patients with partial knee replacements overall report that they're happier with the overall outcome compared to total knee replacements. Um, you can also kind of see this graph that just popped up. This is showing how the knee moves, which is called kinematics, but basically how is the knee moving throughout its range of motion from full extension when the knee is straight to full flexion when the knee is bent as much as it can. And you can see that the line with no symbol is a normal knee. The partial knee replacement is the lines with the little triangles dotting it, and the square line is the total knee. And you can see that the partial knee replacement tracks much more similarly to the intact, normally functioning knee compared to the full knee replacement. Again, they're both good, but partial knee replacements behave a little bit more like a normal knee and a little bit faster recovery rate. Possible risk. Well, unfortunately, all surgeries do have risks. There's a small risk of infection, small risk of blood clots, small risk of developing stiffness after a knee replacement. The data shows us that all of those risks are lower with a partial knee replacement compared to a full knee replacement. Um, Partial knee replacements do have a unique complication or risk, I suppose, that the implant or the other compartments of the knee may wear out over time, and there may be a need to convert a partial knee replacement to a full knee replacement at some point in the future. So that is a risk that's unique to partial knee replacements that total knee replacements do not have. Most patients after a partial knee replacement are returning to the activities that they either want to or need to do or that they enjoy doing. Walking, golfing, biking, swimming. That photo of the person skiing is Lindsey Vaughn. She had a partial knee replacement and she's returned to the Olympics next month. So you can really get back to a pretty normal way of life after a partial knee replacement. Um, and that's really the end of our talk. I wanted to get through this so we can get to your questions. Natalie did inform me that there's a good number of questions, so we'll get to the questions now.
Thanks, Dr. Brown. Yeah, we have the questions coming in, and please feel free to keep entering them. First question is PRP therapy an option for treating knee pain?
So PRP therapy has been well studied, and there is some data that PRP may help patients to have improved pain in the setting of arthritis. There is no data that PRP, which stands for platelet-rich plasma, there is no data that that is capable of regrowing the damaged cartilage, but it has been shown that it can help to alleviate pain for some patients who have knee arthritis.
Okay, thank you. Could you address arthritis between the patella and femur, and if a partial knee replacement is recommended for that?
Oh, that's a great question. So that is a topic closely related to this talk, but it was not included in this talk, but a patellofemoral replacement, which is a replacement of the knee underside of the kneecap and the portion of the femur called the trochlea, which is the groove in which the kneecap tracks. So that can be replaced as long as the medial and lateral compartments of the knee do not show significant arthritis. So that's a great question. There's relatively more patients who qualify for a medial partial knee replacement, which is what we were just reviewing and talking about. But a patellofemoral or a kneecap replacement is an appropriate surgery, and patients do very, very well, but there's just fewer of those patients who meet that criteria. So that's a great question.
Thank you.
And I do patellofemoral knee replacements as well.
Awesome. Dr. Brown, what is the oldest age you've seen to do a partial knee replacement?
Yeah, another good question. So, in the past, perhaps 30 years ago, there were some folks in Boston who really recommended partial knee replacements either as a surgery for very young patients, as a bridge to a total knee later, or for very old patients who may get a lot of benefit but may not need the longevity. And in the intervening time, people have really studied partial knee replacements, and they're actually an excellent option for a vast majority of patients. And partial knee replacements can be acceptable for patients in their 70s, 80s, and 90s who are otherwise doing well but have a severe pain in their knee, and they can really bounce back quickly from that and get back to the activities that we're showing here.
Thank you. There's a couple of questions about playing pickleball after surgery, tennis. I know you mentioned a couple things returning, patients returning to. So how about pickleball, tennis, running?
So, those are higher level activities, and we would allow our patients to ease back into those activities as they continue their recovery. Obviously, recovery is a process, and you have to walk before you can run. But as people get more and more recovered and they get their strength back, we really don't impose any limitations on our patients getting back to the activities that they either want or need to do.
Great, thank you. Someone asked about the status of the substance developed in Germany that is claimed to regrow cartilage and reverse arthritis. Do you have any knowledge about that?
I do not have specific knowledge about that, but as far as I know, people have been working on techniques and methods to regrow cartilage or to do various surgeries arthroscopically to implant substances into the knee or hip or shoulder, other joints that have cartilage damage. And nothing has been shown to successfully regrow cartilage and undo arthritis. There are very specific procedures that may be appropriate for very small cartilage lesions that could be treated with arthroscopic surgery and certain types of cartilage procedures, but I'm not aware of there's no way that I know of to actually regrow cartilage that's currently available.
Thank you. A couple of questions about how long a partial knee replacement will last.
Yeah, that's a good question. And I didn't directly put this into the slides, but essentially what the data shows, because people, this is obviously a popular and important topic. And the data from a meta-analysis, and a meta-analysis is basically when a researcher combines many studies that have been done about a topic and summarize all the results using statistics to make sure it's appropriate to combine those results. So the most recent data shows that if someone has a partial knee replacement tomorrow, in 15 years, there's approximately a 15% chance that they may have to have another surgery on their knee. That same data shows that if you have a total knee replacement tomorrow, that in 15 years, there's about a 5% chance that you may have to have another surgery on your knee because something has gone wrong. So to me, both of those are pretty good success rates. An 85% chance that the knee is still working well with a partial replacement in 15 years, and about a 95% chance that the knee is still working well in 15 years with a full replacement. However, we do have to acknowledge that full knee replacements have a lower risk of having another surgery down the road. So that's how I really think about that question. And different patients weigh these things differently, right? Some people value minimizing the chance of having another surgery at all costs, and other patients say, well, 85% success rate at 15 years is really quite good, and I'd rather have a more normal feeling knee and a faster recovery. So I don't think there's a right or a wrong answer in this topic. I just think there's a little bit of differences in the um, surgeries and the recovery and what one can expect. And every patient has to discuss that with their surgeon and really um, figure out what their preferences are.
Thank you. There are a few questions about doing both knees at the same time for partial replacements. If you recommend them, do you do them?
So that's a good question. And again, if you look at the data, I think that the data more and more is showing us that doing bilateral surgeries, meaning that we replace both knees or both hips at the same time, there is a higher risk of complications. And if you stop and think about it, that sort of makes sense because we're doing double the amount of surgery. And if we're doing double the amount of surgery, that's more stress on somebody's body. And they're also probably going to have a little bit more pain right after the surgery, and they're probably not going to be moving around quite as quickly. So in general, I recommend to people to get one side taken care of. And then as long as everything's going well, we can take care of the other side as soon as 3 months later. But I really try to avoid doing both sides at the same time because I do think the data shows there's a little bit higher risk of complications with doing both at once.
Great, thank you. There's a lot of questions coming in. Um, Question about insurance. So does insurance, do most insurances cover both partial and total knee replacements?
Yes, good question. I'm not an expert at insurance, but in general, the insurance companies, if somebody has significant arthritis, we typically, the insurance companies also rely on that radiographic scoring system and guide that I briefly discussed earlier. And that's a little bit more technical, so I didn't delve into all of that. But if a patient is an appropriate candidate for surgery based on their x-rays and that they've tried those other things we discussed, the insurance company really will approve either surgery, either partial or full knee replacement. And it's really the surgeon's job to interface with the insurance company and get that approved for the patients.
Thank you. How long after a cortisone shot in a knee would a person have to wait for surgery?
Okay, another good question. So we typically the literature really suggests that we should wait 90 days prior to doing any type of knee replacement, whether it's a full knee replacement or a partial knee replacement, or for that matter, a hip or a shoulder replacement after a steroid injection. And the rationale for that is that the steroid injection really functions and works to alleviate pain by decreasing the immune response in the joint in question that's been injected. So inflammation is related to your immune system, and by decreasing the inflammation, it also decreases the ability of your immune system to fight off infections in the setting of joint replacement, and it also probably hampers the wound healing process. So we recommend waiting 90 days from any injection prior to having a joint replacement.
Thank you.
Hmm.
There's a lot of questions. Just going through them. Um, what is the best medicine if ibuprofen and NSAIDs don't work?
So those are really the mainstays of medication that have been studied and recommended as being effective to treat patients with hip arthritis, knee arthritis, shoulder arthritis, with arthritis of the joints of our body. Other medications are not narcotics is really recommended against. They have a host of side effects and can become problematic. So we really recommend against those things. Those are really the two main medications that we know of at this time that have evidence to support their use to treat arthritis pain.
Thank you. This person says they have a patient, so maybe they're a physical therapist or an athletic trainer or some type of provider.
Sure.
They have a patient that had a partial knee replacement but was experiencing calf pain and inflammation shortly after the surgery. Ultrasound was performed for blood clots, none found. However, the calf was drained and blood was removed. The calf muscle was atrophied quite a bit. Any thoughts on what could have caused those calf issues?
Hmm. Uh, First thing to do is to rule out a blood clot, which is great that they didn't have a blood clot. It would really be hard for me to say what sort of I think was going on with that patient without, examining the patient and looking at the imaging and finding out more information about the situation.
Okay, thank you. Let's see.
Some great questions
Yeah,
tonight.
there's a ton of good great questions, and again, we if we can't get to all of them, we truly apologize, but there's like hundreds of questions here, so just trying to get a variety. Let's see. Which surgery center or hospital do you or other doctors perform partial knee replacements? Can they be done
Okay.
at any hospital?
Yeah, great question. So these surgeries can really be performed at any center that performs joint replacements. I personally operate at Abington Hospital, Lansdale Hospital, and Rothman Orthopedic Specialty Hospital in Bensalem. But these surgeries really are appropriate to be performed at any center that myself or my colleagues are operating at and doing joint replacements.
Thank you. Is it recommended, a couple questions about physical therapy before surgery. So is it recommended to do physical therapy prior to knee surgery?
So, great question. The data does show that mild to moderate activity in patients who have joint arthritis, hip or knee arthritis in particular, tend to benefit from maintaining their activity level as much as they can without causing severe pain. If patients want to try physical therapy prior to surgery, I think that's a very appropriate option, and I'm happy to have people try that. But I also do tell patients with a caveat that if you're trying therapy and you've given it a good try and it's only causing you worsening pain, we really don't want you to be overexerting yourself or torturing yourself trying to get your muscles stronger in the setting of severe knee arthritis. So I would really take it on a case by case basis. I think it's great to try therapy, and a lot of people get relief from the therapy. But if it's really not helping you after 2 or 3 sessions, I really recommend to patients to just you gave it a try, but it's not helping you, and not to torture yourself and cause more pain that's not necessary.
Thank you. Someone asked if you could please talk about the length of the operation for a total knee replacement and recovery time.
Yeah, so I think we briefly touched on this before. The actual length of the surgery really doesn't take that much longer. A partial knee replacement's a little bit more delicate of a surgery, and even though we're replacing less of the joint, it probably is a little bit more technically challenging. So the surgeries themselves actually take about the same amount of time, somewhere between 30 to 60 minutes typically. The recovery from the surgery, I think, with partial knee replacements is probably 3 or 4 weeks more accelerated compared to full knee replacements in terms of different milestones that patients achieve, walking without an assistive device, being able to resume walking for exercise and doing activities of daily living. So I think those are general guidelines, but you also have to keep in mind that every patient is different. And if you talk to your friend or your neighbor, their experience is probably going to be somewhat different than yours. These are rough guidelines and work for most people, but everybody's different, and we have to tailor our treatment plans and our expectations to each individual patient.
Thank you. I know we talked about cortisone injections and the length of time to wait um, before having surgery. I don't think we touched on the gel shot. So a couple of questions about if you had any of the like Orthovisc or any of the gel shots.
Yes, so that's a good question, and I think that is a little bit more of a controversial topic. I typically do not have patients wait as long with a viscosupplementation injection, which you mentioned some of the different companies that supply those and the brand names of those. Um, those injections work in a different fashion. And like we talked about, the mechanism of action or how those injections help patients is not really by modulating the immune system. It's more like kind of an oil change in your car that after the motor oil gets worn out and doesn't function properly, you have to change it because the car engine has been using it. So, because it doesn't really modulate the immune system, I don't have the same concern about doing a knee replacement in close proximity to a gel injection. I would probably only have patients wait about a month before we did a surgery.
Okay, thank you.
Good question, whoever asked that one.
Couple questions about the materials used for knee replacements, the implants. So, what the materials are, metal, composite, or just what are the materials used?
Great question. So the tibial component, which is the lower bone in the leg, that component is typically made out of titanium. The femoral component that attaches to the femur is typically made out of a metal called cobalt chrome. And the reason that the femoral component cannot be made out of titanium, which is a metal that goes very well in the body, but titanium cannot be polished enough. And it's really the femoral component that is going to articulate or rub against the plastic liner, which is between the tibial and femoral components. So the plastic liner is made out of a fancy type of plastic called polyethylene, which has very, very good wear characteristics. And those have only been getting better over the years. Back in the 80s and 90s, the polyethylenes that we were using did not have as good wear properties, and that's why knee replacements that may have been done back in those time periods did not have as good longevity as the ones that we're using now. But the cobalt chrome is very similar to what the bumpers on, cars from the 50s and 60s that had that shine polish. And the components look very similar to that because those can be polished to a mirror-like finish and can be very smooth on a microscopic level. So that's really what the parts, the components that we're using for both partial and full knee replacements are made out of these days.
Right, thank you. Someone asked about soft ray therapy as treatment. Are you familiar with that?
I'm not familiar with exactly that term.
Yeah, I haven't heard of that. I'm not sure what that is, so
There is maybe this is what they're referring to, but I do know that some of our physical therapy colleagues have various types of ultrasound or light treatments that help improve and accelerate healing, as well as to possibly help with scar tissue. And there's also some treatments that I've heard of that physical therapists with special training use with sort of special instruments that help to break up scar tissue. So that may be what that patient is referring to, or person with the question, but I'm not exactly familiar with that term, so I'd have to look that up.
okay, thank you. A couple questions about BMI for surgery. So, is there a specific BMI that you need in order to have surgery?
Okay, good question. This is another controversial topic that people have different opinions about. In general, the data shows that patients who have well, let's take a step back. BMI, for those who might not know, is refers to body mass index, and it's really a ratio of how tall someone is compared to how much they weigh. And typically, the data shows that as your BMI gets larger, as somebody is more heavy, their risk of complications, including infections and blood clots and wound healing problems, gets higher. However, those risks are along a continuum. And what I talk to patients about is it's kind of like a speed limit on the highway. If you break the speed limit by a few miles an hour, well, you probably have a little bit higher risk of getting a speeding ticket. But if you're driving 67 and your friend is driving 69, well, there's probably not that much difference in the risk of getting a speeding ticket. So it's really on a patient by patient basis. We do know that there's an increased risk of complications if people are heavier. Um, and I do think that it's important for patients to try to lose a little bit of weight in preparation for their surgery, but it's really on an individual basis, and that risk exists on a continuum that we have to consider in the complete context of the patient's other medical situation and medical problems.
Right, thank you. A couple questions like this, and I mean, I think you touched on, partial versus total, but um, someone asked who is not a candidate for partial knee replacement, and somebody asked, when looking at an individual's knee, what would deter you from performing a partial knee replacement?
Right. So this is a great question, and it really does get back to that sort of radiographic scoring system that we were looking at before that really gives us guidelines based on what people's x-rays look like to help us determine whether they're going to do well from a partial knee replacement or likely to not do well. And patients who have arthritis that's mainly isolated to only one part of their knee tend to do very, very well from partial knee replacements. Patients who have evidence that the arthritis is affecting more than one part of their knee tend not to do well from partial knee replacements and would be recommended to have a full knee replacement. So it's a bit of a nuanced decision. It is typically based on radiographs and also the examination of the patient's knee. And that's really how we guide our decision making about partial versus full knee replacement.
Thank you. There's a couple questions about robotic surgery and if you utilize it.
Yeah, so that's a good question. Another controversial hot button issue. Robotics in orthopedic surgery has become a very popular thing. And the data, I'm a big fan of trying to use data to guide my practice and to help my patients have the best outcomes. The data really shows that robotics in performing either partial or full knee replacement does not make any difference in terms of the patient's overall outcome. I do have access to robotics and I use robotics in certain patients. Um, and those patients would be patients who have had a prior fracture, patients who have a severe deformity, um, patients who have other certain circumstances. Um, the way I like to explain it to people is if you are going from your home to your local grocery store, which you may have done 1,000 times, you typically don't need a GPS machine to tell you how to get there. However, if we asked you to go from your home to a place in Alabama that you'd never been to before, it would probably be very, very helpful to have a GPS machine to tell you how to get there in the most efficient and safe way. So I do have access to robotics and I do use them in my practice. And it's really on a selective basis that I do that. I don't use it for everyone. I don't think it's necessary for everyone, but I do think robotics has an important place. And that's certainly a discussion that's also best to be had on a patient by patient basis.
Thank you. Lots of good questions here.
Very good question.
Let's see. Okay. Um, with partial knee replacement, does the ACL and other do the ACL and other ligaments get removed like they do often with a total replacement?
Okay, very good question. So, in general, the partial knee replacement does not remove the ACL or the PCL, and those ligaments typically both need to be functioning well in order for a partial knee replacement to do well. And again, I keep talking about the radiographic criteria, but this has been studied, and there's radiographic markers that can help guide us to understanding the status of the ACL and PCL as well as an examination of the patient. So there's a variety of factors that we can use to help determine the status of the ligaments, the ACL and the PCL, which are important for a properly functioning partial knee replacement. And we can do that typically prior to the surgery based on the examination of the patient and the x-rays. We typically do not need an MRI to determine that.
Great, thank you. Great questions. Oh, somebody asked, do you use staples or glue to close the wound?
Another good question. So we typically use stitches underneath the skin that dissolve, and then we typically use a type of skin glue. We usually do not use staples. So typically the way we close the incisions is just with a dressing that's waterproof. You can shower right away after the surgery's over, and no staples or stitches need to be removed. We simply need to peel off the protective dressing about 2 weeks after the surgery.
Thank you. Let's see. Sorry, just going through these questions here.
No, great questions.
Someone asked, is it heat or there was a couple questions about this. Is heat or ice better for the reduction of pain in the knee?
Great question. And in general guidelines would be that we would recommend icing for the first, um, 3 to 4 weeks after the surgery. Ice and cryotherapy or cold therapy really helps with acute inflammation to decrease pain and swelling in the initial recovery period. After that initial recovery period, say about 4 weeks, we would generally think that it's okay to start using heat at that point in time. And really, after about 4 weeks, there's not a strong recommendation for either heat or ice. It's really a trial and error thing that whichever one helps the patient the most. And I would really say by 4 weeks, most patients aren't really using too much ice or heat, but really at that point, it would really be a dealer's choice type of a thing that there's no right or wrong answer. It's really whichever modality or option is helping the patients the most.
Great, thank you. There are a couple of questions about when you can drive after having a replacement.
Good question. And this one is a little bit of a nuanced answer as well that's patient specific. But In general, I would say most patients are starting to drive about somewhere about 3 to 4 weeks after the surgery. And there's really three goals that need to be achieved to consider starting to drive. And those would be that the patient's no longer taking narcotics. Narcotics, you shouldn't drive if you're taking narcotics. Number two would be that the patient is walking with a cane and not a walker. And number three would really be that the patient feels comfortable and safe to be driving in their community, in their neighborhood, that they're not going to endanger themselves or their neighbors. So most of the times, by about 3 to 4 weeks, most patients have achieved those three goals and have been able to start driving. Some people do that sooner. Some people it takes a little longer. But those are the rough guidelines and the rough time frame of that question.
Thank you. Another question on cortisone injections. Is there a limit that someone can get cortisone injections? Like how many is too many?
Yes, that's a good question. So the real guideline that we have at the Rothman Institute about that would be that you can really get a steroid injection every 3 months. We think that more frequently than that in general may be not a good idea. The risk may outweigh the benefit. But I have a lot of patients who come every 3 months and they're doing quite well with the steroid injections, and there's really no limit to how many steroid injections somebody can get. If the injections are still helping someone and giving a reasonable pain relief and of a reasonable duration, then we will, I think, giving a steroid injection is a very reasonable treatment option. If somebody's only getting a couple weeks of relief from the steroid injection, that's really not a very effective treatment. But if somebody's getting 2.5 to 3 months of pretty good pain relief from a steroid injection, I think that's a great option. And there's a lot of patients who go with the steroid injections every 3 months for quite a long period of time and are doing very well. So I think it's a good option, and that's kind of the guidelines we use for our steroid injections.
Great, thank you. Someone asked if the ACL has been repaired by cadaver ligament, can partial knee replacement be done, or would it be total knee?
A great question. So the answer to that is if the ACL has previously been reconstructed, whether it's with the patient's own tendon or a cadaver tendon, as long as that repair is still functional and substituting for the function of the normal ACL, we can still do a partial knee replacement. And there's plenty of data and research that shows that those patients will do very well as long as the repair is still functioning well. Great question.
Thank you.
And that actually would go for someone who's had a PCL or a posterior cruciate ligament reconstruction. Those are relatively less common to injure your PCL, but the answer would be the same, that if somebody's had a PCL reconstruction and that reconstruction is still functioning well, they would also be a candidate for a partial knee replacement. Very good question.
Great, thank you. A few questions similar to this. Does delaying a partial knee replacement create a higher risk for needing a total in the future?
I think in general, the answer to that would be no. I think as long as the patient meets the radiographic and clinical criteria to be a candidate for a partial knee replacement, whether they wait a few more years and delay that because they're getting injections or some other type of therapy that's helping them, or maybe the timing is just not right for them. The outcome and the success of a partial knee replacement really should be the same as if they had it, today or in a year from now, as long as the clinical criteria are still met.
Great, thank you. Um, this person said they had a complex meniscus tear 2 years ago. Looks like they
Mhm.
did not have surgery. PT has helped a lot, but they have stage 4 chondral loss. Would partial knee replacement be appropriate in this case?
It sounds like, again, we'd have to go through the clinical criteria and look at the patient and examine their knee and look at the x-rays, but it sounds like that person would be a candidate to have a partial knee replacement. The meniscus, this is a good question that I didn't touch on, but the meniscus of the involved compartment. So if we're talking about a medial compartment partial knee replacement, the medial meniscus would be removed during the surgery, and the partial knee replacement would substitute for the function of the meniscus. So that's a great question, and I think the answer to that question is yes. But of course, these are individualized patient decisions and discussions that would have to be made on a case-by-case basis. But that would, in general, be a patient that I think would be a good candidate for a partial knee replacement.
Yes, absolutely. Thank you.
Great question. Lots of good questions tonight.
Lots of great questions. There's a lot of questions. What do you think about acupuncture for pain relief?
So I think that's another question that is uh, often brought up. I don't know if there's any data per se that shows that acupuncture helps patients with knee or hip arthritis, but I also think that the risks are relatively low. And if somebody wants to try that and it gives them relief, I think that's a perfectly fine option. It certainly wouldn't prohibit them from having surgery in the future. And if acupuncture helps to alleviate pain from arthritis, I think that's a wonderful thing. I'm not sure if there's strong data that supports whether that's true or not, but I certainly think it's a reasonable option to try if patients would like to try that.
Great, thank you. What's a typical length of a hospital stay after a partial knee replacement and a total knee replacement?
That's a great question. And we've actually gotten very good with our post-operative protocols in terms of pain management and also the anesthesia that our anesthesia colleagues are using. So we really have quite a high success rate of allowing patients to return home the same day, whether they have a partial or a full knee replacement. In general, the rates of same-day discharge for partial or full knee replacement are probably somewhere between 50 and 60%, which is really pretty good. The shorter you're in the hospital, really the lower your risk of having a complication. And patients are just in general happier and more comfortable in their own home. You can eat your own food, you can watch your own TV, and you can give yourself your own pain medication and be in an environment that you're comfortable and familiar with. So we've really, it's not really the surgery that we've gotten better at that allows that to happen. I think it's really the education that we do ahead of time. And I think also a lot of the protocols for pain management and anesthesia techniques, in addition to the surgery, have really gotten better and allowed that to happen over the last 10 years or so.
Thank you. Is general or local anesthesia used for the surgeries?
Okay, this kind of dovetails on the last question or my answer to the last question. So there's really two different ways that the anesthesia can be done for knee replacement. One of them is a spinal anesthesia, where the anesthesia doctor would put a local anesthetic in the back, which would numb up the nerves coming out of the spine that go down to the legs and make the legs numb, and then they would give the patient some sedation and we would be able to do the surgery and the patient really would be unaware of what's going on and that is one way, a very good way to do knee replacements. There's also general anesthesia where the anesthesia doctor would use a breathing tube and the patient would be completely asleep, and there's really no evidence that one way works better than the other if you look at millions of patients, but in general, we usually try to use the spinal anesthesia, but that's really a nuanced conversation that the patient and the anesthesia doctor would really have on the day of the surgery and determine the best plan for each patient.
Great, thank you. Do you have an opinion on stem cell injections?
My answer to that question would really be that that's really the same as PRP or a very similar cousin to PRP. So there's no strong evidence that does significantly better in terms of pain relief compared to visco supplementation injections or steroid injections. There is evidence that those things can help patients with pain relief, but I just caution patients there's no evidence, and some marketing might try to convince patients that it's going to regrow their cartilage. And unfortunately, there's no evidence that those injections can regrow cartilage. They can help with pain relief, but they do not help to regrow cartilage.
Great, thank you. I know we talked a little bit about the gel injections, and I think again it's patient case by case, but someone asked about the success rate for gel injections and about how long do they last?
Yeah, so that's a good question. And the answer really is that it depends on every patient. The insurance companies will approve gel injections to be administered every 6 months. Now, some patients they last longer than that. Some patients they wear off sooner. Some patients get the gel injections every 6 months and they get a steroid injection in between the gel injections, that's certainly a reasonable option, and a lot of patients do something like that. But the exact amount of time that the injection, whether it's a steroid injection or a gel injection, would provide pain relief is really it's really a trial and error type of thing that's different for every patient.
Thank you. Another question, is it safe to have the surgery when you are on blood thinners?
Yeah, so that's a good question. A lot of patients may be on a blood thinner for one reason or another, whether it's AFib or maybe they had a stroke or a heart attack, or maybe they've had a blood clot in the past. There's many reasons that patients nowadays may be on a blood thinner. Um, and the answer is it is safe to have surgery if patients are on a blood thinner. Typically, the blood thinner is stopped for somewhere between 3 and 7 days prior to the surgery. And then the blood thinner is resumed typically the day after the surgery. And we would also talk with your other doctors to determine if they had any special recommendations in and around the surgery related to the blood thinner and the exact reason why the patient was on the blood thinner.
Gotcha. Okay. Thank you so much. Right. We have time for a few more. There's a ton still. Again, we apologize if we couldn't get to every question. Sorry, looking through these here.
A
I
lot of good
apologize.
questions tonight.
I apologize. Don't want to repeat any, similar questions.
No problem. Lots of good questions.
Let's see. Okay, this one says it's about the bending of the knee and so if arthritis is preventing your knee from bending more than 90 degrees, would a partial replacement improve that situation?
So the answer is it certainly depends on each patient. In general, when patients have severely or significantly limited range of motion, which less than 90 degrees is a fairly decent amount of restricted motion, excuse me, it may be those patients may be better candidates for full knee replacements. But again, it really is a case by case situation. I wouldn't say that guarantees that you need a full knee replacement, but that would be one thing that would maybe lead us towards a full knee replacement.
Thank you. Are there any contraindications for either surgery in someone who has osteoporosis?
So osteoporosis is a relatively common condition in patients who have knee arthritis. So there's a relative amount of overlap there. Typically, patients with knee arthritis are a little bit older. We also know that we live in a climate that is oftentimes cold. We may not get as much exposure to the sun. And we also know that there's a significant amount of calcium and vitamin D deficiency in the US population. So all these things together lead to the fact that arthritis and osteoporosis or osteopenia, which is the cousin of osteoporosis, and a little bit less severe of bone mineral decrease. So the answer is those two things, arthritis and osteoporosis, are very commonly found in the same patients. And it's really not a contraindication of partial knee replacement or full knee replacement, but it is something to be aware of. And uh, calcium and vitamin D supplementation is probably a pretty good idea for most people that are, uh, living in the United States right now.
Thank you. Question
Mhm.
about arthroscopic surgery. Someone said, is arthroscopic surgery an option anymore? It seems like most orthopedic do, it's either the shots and then the replacement. Do people do arthroscopic surgeries anymore?
So, plenty of people do arthroscopic surgeries, and the answer is it really depends on what your diagnosis is and what is causing your pain and symptoms, and what are we trying to achieve with surgery. The data is really quite clear that in patients who have arthritis, an arthroscopic surgery is unlikely to provide them any pain relief. And that in general is why probably this person is asking this question. But in general, arthroscopic surgery in patients with arthritis is unlikely to provide the patient any significant benefit.
Great, thank you. A couple questions about being allergic to the material used in surgery. Are some people allergic?
So some people believe in nickel allergies, and there is some nickel in the metal that's used to make the femoral components, the cobalt chrome components. This is a very controversial topic in orthopedics in general, and there are nickel-free implants that don't have nickel in them, and that's typically what people are concerned about. And if somebody has a documented nickel allergy, that would be something to bring up with your surgeon and discuss in a case-by-case basis to determine what would be the best sort of option for that patient. So, good question again. A little bit of a controversial topic, and there's a couple different ways to approach that subject, and it's really a little bit more nuanced conversation to have with your surgeon. But there are nickel-free implants that may be an option in those situations.
Okay, great, thank you. Well, I think we're coming down to our closing time here. I know we still have a ton of questions that came in, so again, apologies if we didn't get to them, but I think Dr. Brown did a great job at answering a lot of questions and really great questions that you guys submitted. So, and great presentation, Dr. Brown. Thank you. Thanks for everyone for joining tonight. As I mentioned in a couple comments to people, we did record this, so we will be sending it out, so you'll be able to review it at a later date, and anyone who wasn't able to join will be able to view it as well. If you have any questions or if you'd like to schedule an appointment or a consult with Dr. Brown or anyone at Rothman, you all have my email, so please feel free to reach out to me directly, and I'm happy to assist with that. Again, thanks,
Yeah.
Dr. Brown. Thank you so much. Thanks, everyone, for joining.
Yeah, thank you, Natalie, and thanks everyone for tuning in. Hopefully, we got some good information out there and great questions, very good questions. So, thanks for sending those in.
Yeah, thank you so much. Everyone have a great night and stay safe in this cold and snowy weather.
Yes.
Bye.